Welcome everyone to the Canadian Diabetes Association's 2016 webinar series. My name is Farah Ismail and I will be your host for today. We are delighted that you are able to join us today for our webinar to learn about Your Eyes Matter. Now to start off, I'd like to draw your attention to our survey, which is located at the top right-hand section of your screen. So in order to better serve your needs, we kindly ask that you provide us with your input by completing the short survey towards the end of the presentation, and we thank you in advance for your input. Now, throughout the presentation, you will have the opportunity to type in the question and answer box, and that's located at the bottom right-hand section of your screen. And we ask that you use this for any questions you have for the presenter along the way, and we will be happy to answer them at the end of the presentation. As well, we will be displaying a few polling questions throughout the presentation and would love for your participation. Please note that your answers will remain completely anonymous. Also note you're able to customize your screen so you can expand and collapse them as you see fit, so feel free to do so by adjusting them by dragging down the bottom right-hand corner of each of the webinar pods. Our presentation today will last about 40 minutes in length, and we'll have about 10 to 15 minutes at the end for questions. We do want to remind you that our presentation will be recorded and made available on our Canadian Diabetes Association's website at a later date. So now I'd like to welcome our speaker, Dr. Bryan Friedmann, and thank him for joining us today. But before turning it over to Dr. Friedmann, I'd like to give you a brief introduction. Dr. Bryan Friedmann received a Bachelor of Science degree with distinction from Brock University in 1985. He went on to pursue his Doctor of Optometry degree at the University of Waterloo and graduated in 1989. He has worked as an optometrist in Victoria since then. In addition to his own practice, Dr. Friedmann provides out-of-office services to hospitals, nursing homes, and private homes. He enjoys educating his patients about their findings and their options open to them. So for more information on Dr. Friedmann, please read the speaker bio section, which is located to the left of your screen. And without further ado, I present to you Dr. Bryan Friedmann.
Hello, everyone across the country. My name is Bryan. We're going to take a journey together on the road of diabetes and find out more about it, have some fun, hopefully learn something, and maybe change something. So let's get going. The first slide. No, you want this one. Sorry, technical difficulty. I'm just waiting for something to load up. There we go. This is not a psychometric test, by the way. Just take a look at this for a sec. And there it goes again. Take another look. If you happen to see the words good or evil or perhaps both, then you're on the right track. I want you to think of diabetes as really an evil problem. It affects everything from head to toe, not just organ systems, as you will find out, but every single cell in the body as well. And because of that, it affects the quality of life and certainly enhances mortality. The good news is that while we know about the criminal and the crimes it's committing, we can, just like a Crime Stop program, we have tools to help us stop or reduce the impact of this problem. So go to this slide. There we go. We have a couple of things we're going to go through. Briefly, we're just going to go through some statistics, the cost of care, the causes, the body systems affected, what's happening at the blood level, what's happening at the eye, what are the symptoms of the eye, and what do we do to the eye when it comes to be a problem. We're just going to pause for a moment just to do a poll. So just take a read on this, take off what applies. Let's see. Here's some of the responses that we have received. Got another question coming up. And survey says, that's your responses. Thank you for that. So the statistics, I had a hard time finding Canadian statistics, but the last one, which goes back to 10 years ago, so obviously things would have increased, unfortunately, by now. In 2006, 500,000 Canadians had diabetic retinopathy, which is just a fancy word for saying that the eye was showing damage specifically from diabetes. So 1 in 5 of those folks actually had vision-threatening problems, and of those, 6,000 actually went blind from diabetic damage. And I'm going to tell you that that's 6,000 cases that went blind for totally innocent reasons. The eye is not the source of the problem. It does not cause the problem. It is unfortunately affected by the problem, and it's a sad case for someone to go blind for. The estimates in 2015 said just under 1 in 10 Canadians are going to be diagnosed with diabetes. So this is not a passing fad or just some remote disease that you kind of only hear about occasionally in the news. This is real. You're going to know people, family, friends who have it or are already diagnosed with it. The risk of eye damage certainly increases the longer you have the condition of diabetes, and in fact, just about 1 in 5 people who have type 2 will already show some eye changes at the time of diagnosis. If you have diabetes for more than 20 years and you're taking insulin, you have or will have had virtually some eye changes already happening, and if you are a type 2 diabetic, you would have had, probably 60% of you would have had changes or having changes in your eyes. If you're diabetic, you are 25 times more likely to suffer from being blind than a non-diabetic, and that's a huge number, by the way. Diabetes damage to the eye is actually the leading cause of blindness, and the best, again, estimates about every day we have about 5 people going blind in Canada from diabetic eye damage. Again, I'm emphasizing that's 5 unnecessary cases of blindness. If you're diabetic, you're more likely to develop a cataract at a younger age than a non-diabetic. You're twice as likely to develop glaucoma as well, which is another sight-threatening disease. The bottom line is the longer you have diabetes, the more likely you're going to have eye damage and potential vision changes all the way up to vision loss, and that's what we're trying to prevent. Some other interesting statistics in terms of the non-Canadian side, just going to the world. China and India, by default, having large populations, also have the most people with diabetes, partly because of a growing middle class and deviations from their traditional diets. Diabetes worldwide is the leading cause of blindness, end-stage kidney disease, non-traumatic amputations, and heart disease. And estimates are about 1.5 million people die earlier than would be expected annually in the world from diabetic problems. The other interesting fact I found was worldwide, if you have diabetes, you're twice as likely to have Alzheimer's or non-Alzheimer's type dementia. So again, it's a cruel disease. It has its fingers in lots of pies and affects lots of systems and, again, quality of life. The cost of care is huge as well, and the cost of care is now including your office visits, your hospital visits, medical testing, and medical medications involved. And to the world economy, that adds up to, in 2014 dollars, $825 billion. Again, a huge sum, probably bigger than the GNP for some countries. I could find the stats for the states, and that came out to $105 billion, and so by default, Canada is about 1/10 of the U.S. population. So that means, we can say roughly about $10.5 billion are being spent annually on just the cost of dealing with this disease. And this is not including sick leave or lost production costs. That's a whole different equation. So again, this disease packs a powerful financial punch. If you are able to read this, it says, this is the new vision plan that they've been hyping for 3 months. We get a bag of carrots once a week. Carrots would certainly be great if they could solve our diabetic eye problems, but it's not that simple, so as we'll find out. So let's carry on, and let's figure out what's pushing some of the buttons to give us these problems. Like anything in life, there's never one variable you can take out of the equation and say, great, I'll take this out, and we'll solve our problem. So it's usually multifactorial. We divide the factors into two kind of groups. One's non-modifiable, and by that I mean your genes. No, not the brand of jeans you wear, but the genes that make up your DNA. We have age as a risk factor. You can't modify that, unfortunately. No one's found the fountain of youth yet. Your gender is another risk factor. And then we have factors that the good news is there are things we can modify. Blood pressure is a factor we can change. Smoking is a factor. Obesity. Diet and exercise. So the bottom line is that if we can change these things, we can, that's the good side, as I was saying from the very first slide, of what we can do. If we can try to lose some body weight, 5 to 7% is recommended. Adopt healthy eating habits, which I'll get into later on. You can be physically active. Only 150 minutes a week is what the research says, and that's about 21 minutes a day. That's not much more than walking around a block, taking a quick bike ride. It's not a huge commitment. But the biggest problem is to recognize what's stopping you from changing your habits to try and reduce the impact of this disease. So you have to ask yourself those personal questions. There are other modifiable factors, and one of them is nutrient diversity. And in the world, again, worldwide here, the three main crops that tend to feed us is wheat, corn, and rice. And that's not a lot of phytonutrient diversity in those alone. Modern agriculture certainly allows us to feed more people, but because of its issues, it depletes micronutrients from the soil. So guess what? All those products get added, the vitamins and nutrients back after processing. Antibiotics in livestock reduce our beneficial intestine bacteria, and that's increased digestive disorders like irritable bowel syndrome and Crohn's, and that means although we may eat the right foods, we're not necessarily able to absorb them all because of this problem. One solution, where possible and if affordable, is to change to or try to do organics. If your mother had malnutrition during pregnancy, or you as a child have malnutrition as a pregnancy, let's say you're in a war-torn country or you're a refugee and those kind of issues, those are risks. Those folks will have more likelihood of developing diabetes. If you are at any time obese in childhood or adulthood, again, that'll push the button towards diabetes. Consuming sugars and sweeteners obviously links to obesity, and that also eventually can connect to diabetes. Interesting fact was that if you reduce time spent outdoors and therefore reduce your vitamin D input, those folks will actually have a larger increase of diabetic risks than the people who get enough vitamin D. Pollution, whether it be airborne or ingested pollution sources, affect the metabolic rates and hormone changes in the body, and again, those folks will be more likely to develop diabetic changes. And interestingly enough, poor sleep habits or excess, lights from TV screens, computer screens, street lights at night affects, again, also the body chemistry, and those folks tend to have more diabetic problems than others. The body systems affected are multiple. Your heart, your brain, your nerves, your kidneys, your feet, your eyes, and for some females, pregnancy is affected. So again, this disease pushes lots of buttons and certainly can affect life and ultimately quality of life. So I'm going to take a step back just to help you to understand what's pushing all these buttons. And we're going to start with the blood chemistry level first. I want you all to take a good look at this slide. It's going to be on your quiz later on. I'm only kidding. Really, the take-home message on this slide is if you look at the circle part, at the bottom there, it says hypoxia and decreased blood supply. And those two dominoes, when they line up, cause all the other dominoes to fall. And those are the key foundation concepts of what's happening at a blood level, a chemistry level. So let's take a moment just to understand a bit better. Your blood is, think of it like your delivery, your FedEx things. When you get a parcel, it's roaming around all the streets to find your address and drops it off. Well, in our body, the delivery system of oxygen, nutrients, and removal of wastes are the red blood cells. And in the red blood cells, there's a particular protein called hemoglobin. And hemoglobin binds to those things. And excess sugar, let's just flip to this slide because it shows it better. Excess sugar coats the hemoglobin. Now, when you have a lot of stuff like sugar binding to the hemoglobin, that means there's less parking spots or room in that cargo van to hold other things like oxygen and other nutrients. And basically, it's like having a coat on you over your T-shirt, and you're saying, "Well, I want to take my T-shirt off, but the coat's in the way." So the glucose competes for these binding spots and creates hypoxia, which is the fancy word for less oxygen. It's like a choking effect. So imagine yourself swimming in a lake, and you're in the middle of the lake, and you're getting tired, and you're starting to doggy paddle because you're trying to keep your head above water and breathe. When there's too much glucose binding to the poor red blood cells and the hemoglobin, that's going to put stress on the system. Some of you, or hopefully many of you, have had what's called the hemoglobin A1C test, and on your left side of the chart is the percentage. We measure how much percent of glucose is binding to the hemoglobin molecules. And the nice thing about this test is you can't fake it like the glucose fasting test and say, "Oh, tomorrow I'm going to get my blood test so I won't have my donut or ice cream tonight." This test gives an average of things for the last 3 months. And the way to think about how this test works is if you burn a piece of wood in the fire and you're left with ash, the ash can prove that there was something burnt. So the percentage of glucose bound to the hemoglobin proves how much sugar excess or intake you've had, and that affects the diabetic control. So it's a test you can't really fake. It's a good test for us. So understanding that, let's zoom in on the eye and see what's happening at the eye level. In this picture, all right, so again, I'm going to back up in the little bottom right-hand corner there. You're going to see, the concepts of the less oxygen and the degree of changes in blood vessels. In the A1C testing, we want people to be in a certain range, usually anywhere from 6 to 7, to be under good control. Diabetics are over that, and that's why you do different treatment modes and lifestyle modes to try and bring it into that range so that there's less damage. So just like that swimmer trying to keep his head up above the water and trying to breathe, when the cells of the eye receive less blood and oxygen supply, there is a stimulus to try and get more blood to come in and feed the needy areas. But that, just like the doggy paddling swimmer, can't go on forever. And that's where problems develop. If the doggy paddling swimmer can't make it to the shore, he's going to sink. And this is, in the eye world, that's where cell damage occurs, all the way to enough damage that the poor patient is going blind. So in this poster here, the top of the screen is, if you went straight up, you would be going to the front of the eye, and the bottom is heading the back of the eye into your brain. The pink area in the middle is where your vision cells are and their supporting structures. And I want you to understand that in the eye, the vision cells are like a sandwich system. There's actually blood vessels in front of the vision cells and behind the vision cells. It's really like a huge gas guzzler. When your eye is opened, it takes a tremendous amount of oxygen, nutrients, to run all those little cell engines, and they also, therefore, produce a lot of waste product, and you need a huge blood supply system to do that for us. And just as a point of interest, although light goes through those surface blood vessels, our brain has the ability to tune that out so we don't see the images of the blood vessels. We just see the image that the eye is pointing at. So let's zoom in a little closer. When we have less oxygen available, there are certain signs we will physically see in the eye. On the top left, we see swollen nerve fibers, which are clinically called cotton wool spots, and they're just like seeing a soft, fluffy cloud floating in the sky. They're this whitish, yellowish haze floating on the retina because that's where the vision layers are. When there's stress because of lack of oxygen, the blood vessels try to swell up to increase the volume of blood supply. The swelling causes twisting and bending. And when you see thickening of blood vessels and twisting and bending, again, that's a sure clinical sign of stress. If the blood supply is good, the blood vessels are nice and straight and branch off regularly. The analogy I'd give you is if you were on a mountaintop that was totally smooth and you poured some water down, it would run straight down. But in real life, mountaintops aren't smooth. There's boulders and rocks and gullies, and so a river from the top would run downhill and twist and turn around all these obstructions to head back. And when we see wiggly, thicker, sausage-like blood vessels, we know this eye tissue is straining. The other problem is that the blood vessels become structurally weaker and they can leak blood and blood components like fats and proteins, and we call that hemorrhages. And there are different kinds of hemorrhages in the eye. In the middle picture, you will see like a sideways pyramid, and that's called a flame hemorrhage, and that's on top of the vision cells. When the blood vessels are broken and leaking deeper in, on the bottom left, you'll see what we call dot and blot hemorrhages, because they literally look just like someone put little dots of blood. And if there's leaking on the surface of the retina, we call that a preretinal hemorrhage. So again, if you're a clinician and you're looking in someone's eye and you're seeing this, you know this eye is in a hurting stage. So in the eye world, we sort of divide the diabetic retinopathy damage, and I'm going to say that on purpose. This is the damage that's occurring specifically at the back of the eye where the vision cells are, into two types. The milder to moderate one is called background changes, and basically you will see, again, the exudates, the leakage of the proteins and fats, the little yellow spots. You might see the cotton wool spots, the swollen nerve fibers. You might see some wiggling blood vessels. You might see some small leaks. Again, that shows us that the eye is under stress. The way to see this clinically sometimes, and some of you may have had this test on the bottom left, is a procedure called fluorescein angiography, which is just a fancy way to say that a dye called fluorescein is injected into your arm, and it's just a stain. And as the blood travels through the eye, where there are breaks or leaks, the the dye is released into the tissue, and you'll see just like a chimney having smoke released, you'll get a plume of dye. And if you want to know where your puncture is, very similar to having a bicycle puncture and a tire puncture, you want to identify the place to put the patch. So you pump up your tube, put in some water, and where it bubbles, where the air's coming, you go, aha, that's where I have to put my patch. When you see the dye leaking through the eye, you'll know where your target areas are to fix by using this particular test. So that was the mild to moderate stage, and then we get into the proliferative stage, which is the highly damaging stage, and everything's just basically ramped up. More bleeding, more wiggling blood vessels, more leakage of fats and fluids, and on the fluorescein angiography test, you'll see a lot more plumes and spread of dye going on. And again, an eye in this stage is just like that swimmer who's no longer doggy paddling and is either sinking or it's being pulled out of the lake by some saving rescuer. This is a hurting stage, not a good stage to see. Let's see what that actually looks like in real life rather than diagram. So if you looked at this picture, in the middle, just off to the middle, is the yellow disc there, and that is your eye nerve, and then from there is branches of the eye's arteries and veins. Now, you don't really have to be a doctor to look at this picture and go, hey, this looks pretty good. It's healthy. You got all that red mass of blood by the optic nerve here. That's a pre-retinal bleed. Might be hard to see in this picture, but there are some dot hemorrhages towards the top. Way off to the left, you might see some yellow spots, and that's the leakage of the fats and proteins coming out. And again, this is an eye that's struggling. The vision cells are suffocating. They're not getting their oxygen and blood supply to keep all their engines running effectively. Just going to show you a video just to
Diabetic eye
summarize.
disease refers to a group of eye problems that can occur as a result of diabetes. Without diagnosis and treatment, diabetic eye disease can cause severe vision loss or even blindness. Diabetic retinopathy is the most common diabetic eye disease and is a leading cause of blindness in persons with diabetes. It is caused by changes in the blood vessels of the retina. The retina is the light-sensitive tissue at the back of the eye. A healthy retina is necessary for good vision. In some people with diabetic retinopathy, blood vessels of the retina may swell and leak fluid or blood. In other people with diabetes, abnormal new blood vessels grow on the surface of the retina. At first, diabetic retinopathy may not cause any changes in vision, but over time, diabetic retinopathy can get worse. At first, a person might see spots floating in their vision, or may notice a general blurring of vision. Eventually, diabetic retinopathy may cause vision loss and even blindness.
The back of the eye is not the only part of the eye that is affected by diabetes. We also can move to the front of the eye, and in the front of the eye, the most common effect for the eye is dryness. Now, you don't have to be a diabetic to have dry eyes, but diabetics are very affected by dryness. About half diabetics will complain of that, and if you divide that group up, the insulin folks will show about 57% of them will have dry eye, and the type 2, about 70%. Dry eye can be a very debilitating, annoying, chronic problem, can affect vision, and certainly just constantly dealing with this irritating problem is very debilitating for some in terms of day-to-day life quality. The other problem is cataracts. We're trying to avoid people getting to an end stage where vision is so poor, and in this cartoon with Herman, it's okay, don't worry about it. If you're having such a hard time seeing, then your eye has been negatively affected. So what are the symptoms? Now, the little video there showed some, but I'm going to just spend a little more time reviewing this in a little more detail because I think it's important from your side of the fence to know what you should be looking for. So sometimes your symptoms, absolutely nothing, just like being told you've had a silent heart attack where you said, well, I had no chest pain, my left arm didn't tingle or go numb, but yet the test showed that there's clinical damage to the heart. So nothing is not always a sign that everything's great. You got to still look out for other changes, perhaps. The eye may not have any pain or redness. Blurred vision certainly is a flag. Again, blurred vision can be caused from lots of things, but you want to put the suspicion up if you're getting blurred vision unexpectedly. If you're having double vision, if you have spots in your vision, if you have floaters, cobwebs or threads that seem to float around like dust spots. So in a normal eye, when you look at those boys with the balls, you're going to see the full features. With diabetic damage, because the vision cells have lost the ability to function, in this case, they don't register light. There's dark spots in the vision. And again, that would cause change in quality of life. You might not be able to drive, read, see your faces of your family members. Again, not a fun way to go through life. If you have missing vision, again, that's a flag. Any distorted vision is a flag. Some of you may have done this test called the Amsler grid. It's a very simple test. It's almost like graph paper, and a normal person would say, yes, the lines I see are true and straight. All of them look like they're there. When there's eye damage going on, and again, it's not always just from diabetes, but when there's damage, there will be distortions, bending, twisting lines, or perhaps missing lines. Part of your eye's job is to signal colors, and if you have enough damage going on, color vision may be affected. Again, we're trying to get to the point where we don't get the vision loss. Can't quite make it out, Mrs. Gernbach, and we drove here all by ourselves, did we? Hopefully that doesn't happen to any one of us listening or any friends of us listening. So we know what the crimes being done to the eye are. What are the toolboxes we have to deal with this? So the first one we have is laser surgery to the eye. And the way I'd like you to think about this is if you have a favorite rose bush or fruit tree that you want to make sure it blooms or the best way or gives you the best harvest, you will prune off certain branches that aren't productive because that takes away the resources from the branches that are trying to produce the blossoms or the fruit. When your eye tissue sends out signals that it's choking up, it's not getting its oxygen supply, it's not getting enough cargo vans driving by with the blood cells in them with the oxygen nutrients, new blood vessels will grow. And those new blood vessels are damaging. So the laser is like a fancy pruning shear. It's designed to lop off those new blood vessels. And basically, I hate to use the analogy, but it's kind of like dropping bombs. You go in there with a laser, and as every little pulse creates a little scarring, and you're trying to close off the damaged area around it. Now, like every tool, there's good and bad about laser, and there are certain parts of the eye when you drop the laser bomb, sure, it'll cause scarring and cut off the tissue, but there are certain parts of the eye we do need to keep working regardless. And those two zones, one would be your optic nerve. That's the nerve that sends the eye vision signal to the brain. If you have nerve damage going on, you can't throw the laser at the nerve because you will also kill off the good stuff in the nerve. So we can't laser the nerve part. The other part is something called your macula. And your macula is very akin to if you were playing darts and you are trying to score the most points, you aim for bullseye. Now, bullseye is pretty darn small, but if your dart can hit the bullseye, bingo, you get all the points. In the retina of the eye, the way the vision cells are arranged, our vision bullseye is something called the macula. And it's a very small part of the whole back of the eye. But if light can focus on the macula, that's where color, depth, and detailed vision is registered. And we cannot throw the laser at the macula because if you do that, you will destroy some of the good stuff too. So we have to do something called macular sparing. Now coming back to this current slide, if you look at the bottom left, back to that old test with where we injected the dye and we're watching where little punctures are, we can identify where the leaks are and know how close or far away we can be from the macula. So let's just look at what this kind of looks like. In this eye, this is a picture of someone's right eye. So again, that yellow disc and off to just the left of center is the nerve. The macula in this picture is off to the left-hand side. It's sort of cut off on this poster. And all these funny little yellowy circle spots there, some of them got pigmented scarring already, are where the laser was thrown to try and seal off the stimulus of new blood vessels growing or new blood vessels causing damage to the surrounding tissue. So that's like you going in there with your pruning shears and lopping off all those unproductive branches that are going to take away from the blossoms. And so again, no laser on the nerve and no laser on the macula. And what does macular sparing look like? In this picture, this is someone's left eye, and you can see lots of little yellow dots, which are the lasers all over, but in the center there's a whole area that's not lasered, and that's because that's by the macula. And if you can really see close enough, you will still see in the macula area, there's still some bleeding and twisting blood vessels going on. So it's not that the macula is healthy and not affected, but you don't want to drop your bomb and cause damage to the good stuff that is still at least working. In the eye world, we always try to save the macula because, again, that's where the critical vision is. So we'll sacrifice lots of other parts of the eye, like the old adage of cutting your nose off to spite your face. You know, you got to sometimes do damage to other parts in order to save the most critical part. And this last picture I'm going to show you on this is that, again, this is an eye that's had the end stage. There's so much scarring going on and so much laser work that there's the poor tissue here is pretty well non-productive. And the nerve, instead of being that nice yellowish golden kind of thing, it's all white, and that's a dead, non-functioning eye nerve. So this eye would be blind, and again, the worst case scenario we have in the eye world. Not something we want to see. Now, I say every tool is great. It's got its positives and negatives, and while laser was the go-to tool for a while, science and research moves on, and we've come up with other treatment methods, and they're combinedly called anti-VEGF and steroids. And let's just understand a little bit about what I mean by that. We have to take a step back and just understand that when you have rapidly growing cells in the body, in this poster we're talking tumor cells, but it could be a young baby whose body's growing. It doesn't have to be bad cells. When you have rapidly growing cells, they need fuel, oxygen, nutrients. They got to have garbage removed. And if there's not enough supply, in this case, in this slide, we're using tumor cells as an example. They send a stimulatory signal, something called VEGF. And the VEGF is an acronym for vascular endothelial growth factor. You don't have to remember that. It's just understand that it's a stimulus to tell the blood vessels, hey, you're too far away. We're not getting enough oxygen, nutrients. Come closer. Get more of you over here. We need fuel to keep us going. Now, I'm going to take an analogy to having allergies, whether it's airborne or ingested allergies. If your skin's affected, you get a rash or welts. If your lungs are affected, it might be hard to breathe. If your eyes are affected by allergy triggers, you'll get the itching, burning, tearing eyes. And as a normal response to the allergy trigger, there are immune cells that release stuff called histamines. And the histamines cause, in the eye world, the itching, tearing, burning, stinging eyes. And we say, we don't want to live with that. That's a nuisance. It's annoying. So we take stuff called antihistamines, which blocks the release of those histamines. Of course, that doesn't stop the allergy trigger from happening. It just stops the body tissue from responding. So VEGF stimulates the endothelial cells, and what the endothelial cells are is the building blocks that make the small blood vessels in the body. And the endothelial cell loss is really the domino that spills over and gets all the other dominoes falling to create the damage in the eye. The blood vessels are basically pipes, just like your pipes in your house, and the smallest pipes we call capillaries, and they allow only one red blood cell to flow them at a time. And these pipes are structurally supported by the endothelial cells. Just think like individual bricks making up a brick wall. And on the top of the slide here, you'll see little yellow cuboidal things. Those are the endothelial cells. And when the tumor cells or any struggling tissue sends the VEGF signal, that growth factor, the endothelial cells have to break open so that new roots of blood vessels can grow. And that's the stimulus for the new blood vessels to grow. And unfortunately, the new blood vessels are never as good as the original stuff. And that's where the problems lie. So how do we deliver the anti-VEGF? It is by injection. And the steroids are also used because they have an anti-inflammatory component. The statistics in the research are showing that the VEGF therapy is about successful 75% of the time, which obviously is better than none, but 3 out of 4 cases will be positive that the eye damage can be reversed or at least stabilized. That means also 1 in 4 people may have these treatments and still go downhill, unfortunately, losing vision or permanently. And until better research, this is the current tool we have. Most of the time, the VEGF trials will be done in series. It's not just a one injection. Some of you out there may have had this. It's not only used for diabetes. It's used for other eye problems as well. But if you're diabetic, this may be an option considered. So let's just try to put all this information together. And the best way I've sort of found is to go this way. We can divide life into the movers and the non-movers. And if you're a mover, that means you need muscles. And if you have muscles, that means you need an engine and you need fuel, and put those together, you create energy. And in the body, the muscles of the body plus oxygen plus fats and sugars combine in the engines of your body called mitochondria, which are in your cells, to produce energy. Energy sustains life. The end products of all this is water, carbon dioxide, and energy. Now, water we sweat out, we breathe out. Carbon dioxide we breathe out. And energy is used to keep all the engines running in our body. Diabetes basically is the problem interfering with all this energy-forming substance. And uncontrolled sugar metabolism in the body, in the eye, can cause that, blindness, a lack of vision. And again, we're trying to avoid getting to this stage. Diabetes is often being called a disease in the starvation, that's a starvation in the face of plenty. So in other words, just like this gentleman being stuck in the middle of the ocean, surrounded by water, and saying, hey, I'm thirsty, anybody got something to drink? The ocean water is not going to sustain him. Your body does need sugars and fats to help it run. But if it's not accessible, it's like owning lots of property and houses, but you say, I want cash to buy this. Well, you don't have any liquid cash, and your body cannot go and access these stored up uses of oxygen, sugars, and fats to keep the engines running. Then those engines break down, and they ultimately degenerate all the way to causing cellular death. So what can we do? We know what the crimes are. We know what's happening. Hopefully you've now had some understanding of what's happening at the cell level, and in my case, the eye level. What tools can we use to avoid all this? Exercise is one of the main ones. Doesn't matter what exercise you do. Everyone's going to find their own groove as to what works for them. But exercise obviously increases circulation, which brings more oxygen and fuel to the cells and helps with removal of wastes. Again, the stats show you only need to do about 21, 22 minutes a day. It's not a huge commitment. Obviously, more is nice. There are certain lifestyle choices we can do with diet and food combinations. One of the best advices I've come across over the years is to eat real food, not too much, and mostly plants. Obviously, what you eat becomes the building blocks that make up your body. So if you put crappy stuff in, and I'm not saying never eat a candy bar or, potato chips, but if that's your main meals, those are so processed that your body's not going to make healthy, viable tissue. It's going to inflame, it's going to degenerate quicker, and it's going to die off quicker. In the eye world, we have foods that are really good for us. The dark leafy greens, like kale, spinach, broccoli, collards, chard, are really good for the eye. Egg yolks and eggs are really good because they're low in saturated fat. Contain substances called lutein and xanthinin, which help our macula stay healthy and work well. Seafoods not only provide protein sources, but are also the omega-3s. And the rule of thumb is to eat the smaller fish, so salmon, sardines, mackerel. The thinking is that the larger fish, like tunas and so on, because they have larger body masses, their bodies will also be holding on to pollutants, specifically mercury or other toxins that we end up ingesting as well and creating problems that way. So the smaller fishes don't likely have them as much. Red wine is a health benefit to circulation issues, not just for the eye, of course, but for the whole body as well. 3 to 5 cups of coffee. So if you're a coffee fan, there is good clinical evidence that this does help with the type 2 diabetic issues, reducing the risk of, and also for heart. Please drink your coffee with food rather than just straight up. It helps with absorption effects. Obviously, if you're a smoker and you can quit, you're doing yourself a huge favor because smoking competes for those oxygen binding spots. And again, oxygen at the end of the day is the fuel that drives the whole body engine. There's a survival concept called the rules of 3. We can live for 3 weeks roughly without any solid foods. You can live for 3 days without any water. I'm not saying you're happy and you're healthy, but you will be alive. But you can't live without oxygen for roughly 3 minutes. After 3 minutes, you become brain dead, and that's it. That's how vital oxygen sits at the very top of the pyramid of life necessities. Losing weight, all those extra body tissues, even though they may not be doing much, they're still living tissue. They still need oxygen, nutrients, and waste removal, and that means there's more blood vessels and pipes that have to form to feed those areas. There's more blood volume. Your heart has to work harder, and that creates a whole lot more stress on everything. And medications certainly can help reduce that small blood vessel damage that occurs. And by the way, that the endothelial damage that I showed you in the eye is not just in the eye. It's happening at every cell level throughout the whole body, head to toe. So the bottom line I want you to really understand is that the most effective way to reduce the human and financial costs of diabetes, which in my world includes vision loss, is to prevent you folks from getting diabetes in the first place. And the great toolbox is that diabetes is one of those conditions that really self-care is a huge component of what we can do to reduce the impact of this condition. And so just for fun, we're just going to have a little quick pop quiz. Okay, so diabetes defined as, please take a quick read. And survey says, bingo, wow, everyone got it right. I'm glad you were all paying attention. That's right. No one's answering that one yet. So the answer is diabetes cannot be cured by diet, exercise, and medication, but it certainly can be alleviated and reduced. People who are obese are more likely to develop type 2 diabetes. And hopefully we have convinced you that that is certainly true. Well done, everyone. Prediabetes is considered a reversible condition. Survey says the answer is true. Yes, that's where the toolbox of the diet, exercise, lifestyle choices comes in handy. Before the pendulum can swing into that critical damage stage where the A1C readings are high, you can preempt that. Well done, everyone. Type 2 diabetes can cause long-term damage in, and hopefully I've convinced you all that it is all of the above. Well done. Because every organ, in fact, every cell is affected. With type 1 diabetes, the body does not produce insulin. Survey says that is true. That is the problem with type 1. You're born with an error of some kind. In your young years, your pancreas cannot make the insulin, which is the key that unlocks cells from getting their sugars as fuels. When the body does not respond to the insulin it makes, this is called. Survey says type 2. Perfect score, everyone. Well done. Yep, so even though your body, your pancreas is making the insulin, there's receptor damage or other chemical damages, and we need help to get the usage of the fuel, the blood sugars, to be used up. If there are any questions, we'd be happy to entertain any.
Great. Thank you very much, Dr. Friedmann, for delivering and developing actually such a great presentation on retinopathy and really helping us understand the relationship between diabetes and our eyes. So we have quite a few questions coming in. I know we are close towards the end of the hour, so we would like to respect everyone's time. So we'll do our best getting through a couple questions at the moment. And for the questions that we do not get to answer today, we do apologize, but I hope you'll email us at webinars@diabetes.ca, and we'll be happy to answer your questions promptly. So Dr. Friedmann, I'll start us off with our first question here. Our participant has said, our blood sugar goes up and down during the days, and that has effects on our vision. My question is, what is the best time to have an eye exam to get prescribed eyeglasses?
So great question. There is no black and white answer because it's an individual-based response depending on the meals you have, the frequency of the meals, and the metabolic rate that your body processes all the sugars and nutrients coming into the system. The fact that you recognize vision can change today is absolutely correct. The curvature of the eye changes depending on the amount of fluid in and out of the cells, and sometimes you may need to do 2 or 3 readings, one in the morning, one in the afternoon or midday, and then sort of draw a line in the sand as a rough average. But if you can control the diabetes itself, the A1C level, to be stable, then you should also have much more stable vision outcomes.
Great, thank you for that. I'll move on to our next question. What would you say about sugar substitutes such as Splenda and how those impact diabetes and our eyes?
Okay, without getting into too much biochemistry detail, the bottom line is that research has recognized that sugar substitutes, while they certainly intention is to reduce calorie intake, but it does mess up the metabolic processing system of the body. And again, for diabetics or pre-diabetes, those push the buttons I'm speaking generically because unfortunately not everyone's always going to respond. Not every smoker gets lung cancer, so not everyone who uses artificial sweeteners is necessarily going to develop diabetes, but it is a risk factor. It depends on how much you use, the dose loading, and your body's response to that. So, if you can avoid it, I would say better for you for that, yeah.
Great. Thank you for that response. We have had a couple folks wondering what the rule of thumb would be around how often you could recommend a vision test or checkup for somebody living with diabetes.
Well, I'm practicing in British Columbia, and there are no regulations. I mean, you can come in as often as you need if there's a problem. All things being equal, though, if your A1C is under control, then the spin-offs that you get to the eye will be, negligible from the diabetes to none. Now, of course, the eye can still suffer from other problems. Just because you have your diabetes under control isn't a magic suit of armor that says no other problems can happen. But the Canadian Diabetes Association certainly recommends an annual eye check with your practitioner to check for those changes in the eye, and that gives you feedback on how your body control process is going on.
Great. And just to piggyback onto that question there, would you have any other additional recommendations for, say, somebody who's as young as a 13-year-old boy that's living with type 1 diabetes in terms of how often he should see the eye doctor?
Well, because the body itself is growing at that age, and there's also going to be puberty-related changes. The eye is certainly fair game to change a lot as well, but insulin dependency would, again, if you remember from the early slides, anyone who's insulin dependent is most likely going to have some form of eye damage or changes guaranteed at some point along the journey of life. If you know those changes are happening, then you can encourage the patient to tighten up on their control, or maybe need to modify medications and or lifestyle diet-related issues to try and swing the pendulum in to a better, tighter control. And a younger body, like a teenager, may need, could be every 3 to 6 months, depending on how their body systems are responding.
Okay, great. Thanks for that. And I'll just take our last question here. One of our folks has asked, once you have retinopathy, can you still avoid blindness, or can you only prolong it till the time it takes to happen?
No, we hopefully want to avoid the blindness factor. We hate the B word in the eye world. If you remember, there were two, sort of a mild stage of diabetic changes where you might see some early struggling tissue changes with blood vessels, swollen nerves, etc. And that's not a stage where someone's going to go blind. It's in the proliferative stage where the tissue is struggling so much that it's going to virtually, be like that swimmer, not able to keep doggy paddling, and it's going to sink. When the changes are that bad, then the eye is much closer to going blind. So then we have to be very aggressive with the toolboxes in terms of the eye treatments to try and contain the eye damage, and then you have to look at the big picture of what's happening in the whole body and get that diabetic patient under control. I said going blind from diabetes is really a very unfortunate, technically a totally preventable reason from going blind.
Okay, great. Well, thank you so much, Dr. Friedmann. Folks, that does conclude our webinar today. I'd sincerely like to thank Dr. Friedmann for speaking on behalf of the Canadian Diabetes Association. It has been a really great learning experience. I do want to remind everyone that our webinar will be made available online in the coming weeks. And we do have one more webinar that's coming up at the end of this series, and that'll be happening next week on October the 12th, and we'll be talking about research with our very own Dr. Jan Hux. So please remember to register for that at diabetes.ca/webinars. As well, this is a listing of all of our upcoming CDA Expos happening in your community. So our Expos are free events for people living with diabetes and provide individuals with an opportunity to interact with experts as well as your community networks in order to help you live better with diabetes. So if you'd like some more information and to register, please visit diabetes.ca/expo. And for those of you looking for more support and resources to live well with diabetes, feel free to call our 1-800 number. So that's 1-800-BANTING, 1-800-226-8464. Thank you for joining us today. We hope you've enjoyed learning with the CDA, and we look forward to your participation in the future.